Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. Today we're going to talk about new papers and data sets in multiple myeloma. We have a great faculty today, Dr. Amrita Krishnan from the City of Hope Cancer Center in Duarte, California, and Dr. Robert Orlowski from the MD Anderson Cancer Center in Houston, Texas. Today we're going to be focused on multiple myeloma. As with so many parts of our Year in Review series, it's really difficult nowadays to even get through some of this in an hour. We will be talking about the use of non-approved agents and regimens as part of this discussion, so check out the package inserts for the approved agents for more. As with all of our Year in Review series, I met with the faculty individually, separately, in the last week or so to record a presentation. Those presentations are both in the chat room, and they really go over all the papers that we are really going to focus on today. There's a long list, and they go through them very comprehensively. These are fantastic presentations, so many really great papers that came out. Today, we're really going to pick out some of the most important presentations, and rather than go through in detail the slides, really get the faculty's take on clinical implications, as well as implications for future research. So we'll start out in a minute with Dr. Orlowski's papers, focusing on mainly upfront therapy, and then Dr. Krishnan's presentation on CAR-T, bispecifics, ADCs, et cetera, et cetera. If we have time, we'll also pick up some of the presentations that just occurred at the recent ASCO and EHA meetings. So I mentioned the fact, I want to just chat a little bit about this question that came up in my mind. I was thinking about myeloma in 2006, so 20 years ago. We know about a third of our audience has been in oncology less than 10 years, so 20 years ago, to me, not that long ago. But when I was talking with Bob during his presentation, I was asking him, what was myeloma like in 2006, just 20 years ago? 2006 was 1 year after the adjuvant trastuzumab papers were presented at ASCO, and 1 year before the iPhone came out in 2007. So sort of a long time ago, but for other people like myself, not very long. Bob, 2006, was just about the time that RVD was coming along. Of course, after that, we saw the anti-CD38 antibodies. I also got inspired to ask you about this today, because I was mentioning we're doing this program on non-small cell, and I was working with Professor Parole, who's a great speaker. This is going to be a great program next week, incidentally. And he was mentioning that the current data right now for first-line therapy of metastatic ALK-positive disease with lorlatinib, the ALK inhibitor, is now over 7 years, compared to 18 months with EGFR, with osimertinib, another 6 months, 24 months or so when you add in chemo. So both biologic therapies, but very big difference in PFS. And that got me thinking about what's going on in myeloma, because what I've been hearing from you all in terms of quadruplet therapy, to me, is amazing. And I just want to make sure everybody's on board, because I'm not sure I was actually until I was talking with you. So a very simple question, Bob, and then we'll get to Amrita, which is, let's talk about standard risk, just to keep it simple. And I know transplant patients are going to do a little bit better, but let's just sort of blend them together and get a more global view of what myeloma was like then and what it's like now. So Bob, 2006, the patient asks you, they have standard risk disease. I know you can't be that specific, but in general, how long do you think it'll be before I need another therapy? How would you have answered it in 2006, and how would you answer it right now?
Well, for a standard risk patient in 2006 who would have gotten a stem cell transplant and then lenalidomide maintenance, we probably would have said that the median progression-free survival was on the order of 3 to 5 years before they would need a second line of therapy. And the current data that are being aggregated after quadruplet regimens, again, transplant, consolidation, and dual agent maintenance, it's looking like that number is getting to about 15 to 16 years. Now, keep in mind that standard risk patients, and they're healthy because they're on trials and they're getting a transplant. So for the folks in the community, the numbers are probably going to be a little bit lower because you deal with patients who have more comorbidities. But that's a pretty dramatic increase over a relatively short period of time, probably in part due to the CD38 antibodies.
Amrita, I'm curious about your thoughts. I don't know if you're as optimistic as Bob is or when he talks to this patient, but again, just to put in context, when you talk about whether it's 10 or 15 years of PFS for first-line therapy, metastatic ER-positive breast cancer with a CDK inhibitor like ribo and endocrine therapy, 28 months. HER2 positive, and next week we're going to talk about Destiny Breast 09, TDXD, and pertuzumab 40 months. You guys are talking about 10 or 15 years. It's like amazing to me. I really wonder whether I didn't really grasp it. Amrita, any thoughts about Bob's numbers and about this question?
I think Bob couched it well, that in the best case scenario, which is a fit patient, standard risk disease, MRD negative, then over 10 years is a reasonable expectation. I think if you amalgamate everything together, I guess I tend to give more of the ballpark of about 8 to 10 years. The only caveat, and this is where I have to just say I don't know, is the trials which quote that long PFS continue maintenance until disease progression. And I just don't think that that's where we are practicing now with that paradigm. And we just don't know. We're moving into the unknown of, do you get that same response if you stop maintenance earlier? Smaller studies suggest yes, but that wasn't the trial with the 17 years. So.
And of course, we were also seeing MRD being introduced into that decision. We'll get into a little bit of that later. But Bob, just final question before we go on. Again, just taking a breath and getting kind of more of a global view. When you see this really stunning advance, and a lot of it, I think, it seems, as you were saying, is really related to daratumumab and anti-CD38. Why is it that anti-CD38, Bob, in your view, is so effective?
I think a couple of things. Number one is that the added toxicity of that as a fourth drug into the platform is relatively low. People tolerate it very well. The other benefit is that it has multiple mechanisms of action, which include a direct anti-myeloma effect, but also a change in the tumor microenvironment with decreased T regulatory cells, and also expansion of T cell clones that have anti-tumor activity. And anytime you can hit multiple avenues that go after the tumor, that's when you're going to have this really synergistic effect where the combination is better than just the sum of each of the parts.
And just one more question back to you, Amrita, because I know only fairly recently you became head of the SWOG myeloma group. I'm curious in terms of ongoing trials right now, in terms of really even further improving the initial therapy. Obviously, you have bispecifics at an issue. We'll talk about belantamab also as part of upfront therapy, even CAR T therapy, et cetera. From your point of view, where is the interest right now in terms of first-line trials? And what's SWOG doing?
Mm-hmm. I think there's two, and I really can't take credit for this because the genesis came during Bob's tenure of Bob's administration, I should say. But we carried that on. So two things. Number one is the dramatic study. I do think that is a very important study. It looks at daratumumab lenalidomide maintenance compared to lenalidomide single agent maintenance with an MRD fixed directed therapy. So there's a fixed duration maintenance question as well. And that's going to have a readout next year. So hopefully it can at least answer the first question, Dara-Len versus Len, irregardless of your induction regimen. So it's not a whole package. It's truly the maintenance question. The second thing, I think Bob very adroitly sort of said, what is the future and where are the biggest spaces we still need to impact? So he quoted the 17 years for standard risk. High-risk myeloma is still a huge unmet need. And that's where new agents can impact. So there is a SWOG trial that's going to open, hopefully by September, of high-risk newly diagnosed myeloma using T-cell engagers in the induction setting. So RVD-Dara-Tech versus RVD-Dara with also MRD endpoints.
So, well, you see the agenda here. We're going to hopefully we'll get to ASCO and EHA in terms of the papers that were there that may be relevant also in terms of this question. But let's move forward now and talk about some of the things that both of you got into, and this kind of really does lead into the issue of therapies in the upfront setting that Bob was including there. And so first, daratumumab for smoldering myeloma. Bob, again, we're not going to go through in detail the slides of this. This is the Aquila study that I think probably a lot of people have heard about. Can you comment a little bit about sort of where that landed, Bob, in terms of practice patterns? Or is this something that you think is part of practice at this point?
Well, I think it's definitely a big milestone because it's the first time we've had a therapy approved for high-risk smoldering, and there's a definite benefit in terms of reducing the risk of progression with a relatively tolerable side effect profile. I do think it's just the first wave because there are other studies looking at triplet regimens, anti-CD38, Len, and Dex, and there are also efforts looking at CAR T cells and T cell engagers. I would definitely think about putting, though, a high-risk patient either on one of these trials or on DARA. And the group I would particularly target are the ones that are high risk and their numbers are climbing over time, because those are people who are really, even within the high risk group, at much higher risk. If you've got a high-risk patient whose M protein and free light chains are relatively stable, they're somebody who I might still think about watching and waiting.
Amrita, a quick question from the chat room. Hassan wants to know how you define high-risk smoldering myeloma.
So that's a great question. Aquila is a little controversial because it was an amalgam of multiple different high-risk definitions. Most of us use sort of the IMWG and the Mayo 2220 because it's simple and easy, right? So 20% plasma cells, M spike 2 or more, kappa lambda ratio over 20, and the cytogenetics also, high-risk cytogenetics playing into that also.
So I should have mentioned also we were talking about high-risk disease. I don't know if we're going to get to it in the final section. The slides, which again are in the chat room if you want to check it out. We put the title slides for a really great symposium at ASCO, Sagarlonia led, on high-risk myeloma. There are 3 fantastic presentations. I highly recommend it. All right, getting back to your presentation, Bob. Quadruple therapy, transplant eligible, and then we'll get into transplant ineligible. Comments on Perseus, looking at daratumumab, and relating to MRD outcomes as well. And then also the ESA KRD approach to this and new data on that. Anything you want to say about that, Bob?
Well, I think in particular, the Perseus analysis showed that even for high-risk patients, adding the anti-CD38 antibody does improve their outcomes. Now, they're still not quite as good as a standard risk patient, but definitely you should give an anti-CD38 to both groups, standard and high risk. And you now have the option to either do a CD38 like DARA or isatuximab, and you can do either bortezomib or carfilzomib based on these various studies. And MRD negativity data with these quadruplets are really incredibly high and very impressive.
Amrita, anything you want to add to that, again, in terms of the transplant eligible patient? Also, we'll talk later the fact that there's a new trial with the Determination 2 trial that is going to be a very interesting study. I want to get your thoughts on it. But anything else you want to say about this situation and these two trials, Amrita?
I think the one other thing that these trials did show us, because there's always been a question for the high-risk patients, do you need a proteasome inhibitor as part of your maintenance? And these trials show us that you can do well with a CD38 antibody in combination with the IMiD as your partner for maintenance and high-risk disease.
That's a great point. All right, Bob, what about quadruple therapy transplant ineligible patient? We saw an update of the Cepheus study, DVRD. Any comments on that?
Well, same story here as for the transplant eligible patients. If you can give a quadruplet to a transplant ineligible patient, if they're fit and robust, it definitely makes a big difference. And again, that can be either Dara VRD or isatuximab VRD. The main difference in the past has been that, of course, Dara was available either IV or sub-Q, whereas ISA was previously only available by IV, but there is now coming, hopefully soon to be FDA approved, an on-body injector, which will allow for subcutaneous therapy. And you flashed the slides of the benefit study here. And that's actually a very interesting trial because it tested whether you still need bortezomib, and actually it showed a higher MRD negative rate if you did include bortezomib. So clearly there are some people, maybe if they've got bad baseline neuropathy, that you don't want to give this drug to. But if you can, bortezomib is still helpful, and it was given once weekly in that study.
So the next topic Bob addressed is, as he was kind of alluding to before, is now sub-Q isatuximab, and of course hasn't been available, and that's why Dara has been used. I don't know how many people have actually ended up using this, but probably in the near future. Bob, anything you want to say about your understanding of this and how it's going to play out, and particularly the impact on nurses?
For sure. This is actually a really cool technology because you can see the photo of this disc. Essentially, the drug is reconstituted in the vial, loaded onto this disc, and then just placed on the patient, and you can then activate the injector port. Some of these devices can actually inject more than one drug, which could be really cool down the road. But what they did is looked at it in the relapsed setting with ISA-PD. One arm got PD with IV isatuximab. The other arm got POM and Dex with the subcutaneous version. The two arms were identical. And as you alluded to, patients were happier with the sub-Q dosing, and nurses were also happier because they don't have to be there injecting over 5 minutes in a subcutaneous space. And I think it will make potentially home therapy an option once you've given maybe a cycle or two in the office to make sure that there aren't any major injection reactions.
Sam Rita, the chat room wants to know whether you consider ISA and Dara interchangeable. I mean, obviously, you have the practical issues here in terms of this new device, but what about the actual efficacy, tolerability? Anyway, I think people have gotten the idea that it's hard to separate the two from both efficacy and tolerability. I've heard other people say theoretically, or maybe there's some clinical data, there may be some ones better than the other. What's your overall take on this, Amrita?
Mine is that they really are equivalent. And so I know you're going to talk about Determination 2, which uses ISA, for example. There was another ASCO presentation, Heraclea, which had a subgroup of patients who had prior daratumumab who then got treated with isatuximab. I still don't think that means they're different. I think it just means that you can respond again to a CD38 inhibitor if you wait long enough of a washout.
So we were talking about Dara as maintenance therapy, Bob, and you also talked about the Auriga study. Can you talk a little bit about that and whether you think this is a strategy that's, quote, ready for prime time?
Yeah, I mean, Amrita mentioned this a little bit at the beginning, where this study looked at people who are MRD positive after transplant and randomized them either to Len or to Len-Dara in combination. And not surprisingly, the group that got the Len and the Dara combo did better in terms of achieving complete response and also in terms of achieving MRD negativity. So definitely, if you are MRD positive after transplant, I would definitely go with the combination. I do think that more and more there are fewer people who are still MRD positive after transplant because our induction regimen is so much better. But you can see here very high rates of conversion to MRD negativity at 10 to the minus fifth and even 10 to the minus sixth with the combination.
We kind of alluded to this before, Amrita, but what about the practical issue of MRD as a way to decide whether or not to hold off on maintenance therapy? You know, we talked about maybe they're going to have PFS of 10 or 15 years. Are they going to be on maintenance, lenalidomide all that time? You know, the idea of using MRD has made a lot of sense for a long time, but again, is that something you're actually doing?
Well, I mean, we are doing it routinely in all our patients post-transplant for. It's obviously prognostic, but now it's also becoming used to help guide therapy. And there was another ASCO abstract. There was a long-term update from Forte that looked at outcomes of patients who had sustained MRD negativity. And it really showed that they had a significant PFS benefit, even compared to patients who went negative, positive, negative, right? Just the concept of having sustained MRD negativity is very important. And then it ties into this idea of them being able to discontinue maintenance therapy.
So let's talk a little bit about cell mods. We've already referred to the fact, and we'll talk about it later, that there's a cell mod right now in the Determination 2 trial, iberdomide instead of lenalidomide, kind of interesting. But what about mezigdomide, Bob? You talked in your talk about the Successor 2 trial. What did they look at there? It's already published in Lancet.
For sure. So these are the next generation of cereblon modulating drugs. So they're essentially better versions of lenalidomide and pomalidomide. They bind more tightly to cereblon, and they are stronger in terms of immunomodulatory properties. Iberdomide actually has a PDUFA date that's coming up this summer. So you may be able to start using that beginning in September or the fall. Here, what they did is in patients with one or more prior therapies, you could get either carfilzomib and dex or mezigdomide with carfilzomib and dex. And you can see in that blue curve that the triplet really did a lot better. And to me, the real excitement around Iber and Mezi is the fact that they seem to be able to reduce or reverse T-cell exhaustion. So I think for people who get a CAR T or a T-cell engager who maybe develop some T-cell dysfunction, rather than going immediately in the next line of therapy to another CAR T or T-cell engager, I think that combinations like this would be really great, both in terms of efficacy and in terms of, if you will, priming the patient's immune system for the next immune modulatory impact.
And also, Bob talked a little bit about the Excalibur study in relapse disease, now looking at iberdomide. And we see there's a press release out there, too, that talking about, this is from the Excalibur study, but evaluating iberdomide, it's apparently going to be positive. What about the newly diagnosed patient? Bob, one of the things, again, Paul Richardson mentioned to me when he was talking about Determination 2 was the idea that maybe these new cell mods, example, iberdomide, you wouldn't see the second cancers. I don't know. I think that's maybe more translation-based at this point. I'm not sure we have the data. Also, what about tolerability, quality of life, Bob? Any differences with these cell mods, particularly iberdomide? And you buy into this fact that maybe there are going to be less second cancers?
I think from a second cancer perspective, we probably need longer follow-up before we can conclude that that's the case, but there's definitely hope in that regard. And in terms of toxicity, it's kind of interesting because if you want to think about the Len and POM paradigm, Iber is kind of a little bit more like Len because it has less hematologic toxicity, whereas Mezi is a little bit more like pomalidomide because it has a little bit more heme tox. And you do have to be a little bit more careful with Mezi to watch counts and also to use additional antibacterial prophylaxis, for example, trimethoprim sulfamethoxazole. But there are now studies looking at replacing Len with iberdomide. Here were some data from the phase 1/2 IDEAL study where it was Iber with Dara, bortezomib, and Dex. And you can see overall response rates of 100% and definitely what look like good progression-free survival as well as overall survivals.
And again, here's some of the data they have in these early studies looking at toxicity. This is the Determination 2 trial. Of course, everybody remembers the Determination trial presented looking at the question of transplant, which showed benefits with PFS but not survival. Amrita, I'm curious what your thoughts are about this. Pretty interesting. Again, they are using isatuximab, not daratumumab. They're using iberdomide, not lenalidomide. So that's the backbone of the study. It's MRD guided. And then there's at one point in the MRD positive patients, they're randomizing between transplant and bispecific linvoseltamab. Any thoughts about this, Amrita?
I do like that randomization because it really does ask the question that many of us are thinking in the future, right? What is the role of autologous transplant as consolidation when you have effective T-cell directed therapy? So I think that arm is great. The induction, I think, speaks to Bob's points about tolerability there. I don't have the expectation you're going to have significantly higher MRD negative rates than what we already see with the traditional quad inductions.
So we'll see how this plays out. And also, we won't get into it today, but Bob has done work on, of course, Paul's so interested in the Duffy-Knoll issue that came out with the determination specifically in the African-American patients. And I think that's going to be further explored with Determination 2. I think it's one of the most fascinating things in oncology, period, that whole Duffy-Knoll story. But let's move on and talk about CAR T right now. And Amrita, the first thing you talked about in your presentation was long-term outcomes with CAR T, specifically with cilta-cel, and made the most common journal everybody reads, the New York Times there. But, it was interesting, too, when I think back when, at first, when CAR T first came out, everybody was all excited. To me, I felt like then there was a sort of down period where people were a little not so excited. And now it seems like people are more excited than ever. And obviously a lot of this is about the long-term benefits and particularly about the effects of cilta-cel. Anything you want to say about that, Amrita?
I mean, I think the excitement was really, of course, because these are patients who 6, 7 prior lines of therapy to have such high response rates was astounding. I think to your point, when the excitement went down was because you couldn't get cilta-cel, right? Just the waiting list. Right. So you were losing patients. And that's how, honestly, in a way, why the bispecifics got a foothold, right? Those trials were done 2019, 2020. And those were patients who also could have gotten CAR T but couldn't. So, it was an easy choice to then put them on other therapies. The excitement's resurged because, of course, now it's still an issue in terms of access, but there is much easier access at CAR T centers to get cilta-cel, and the CARTITUDE-4 data, of course, using it in earlier lines of therapy now showing a true survival benefit is really, I think, key.
Bob, any updates on where we are today in terms of the delayed neurotoxicity that's been seen with cilta-cel, the Parkinsonian things, et cetera? Where are we right now with that in terms of avoiding it and dealing with it?
Yeah, for sure. I think also getting back to your previous question about excitement, I think at the beginning when the patients were progressing, it looked like that curve was going to continue to go
Right.
down. But now we're beginning to see a plateau, and we actually had a meeting earlier this year with a lot of experts to talk about a cure definition. Because when you get to 5 years out and there's still a third of people after five or more prior lines that haven't relapsed, the CURE word becomes reasonable. But in terms of neurotoxicity, I think that what we're beginning to learn is that if you do better bridging therapy and if you do a better cytoreduction before you reinfuse the CAR T cells, you definitely reduce the risk of cytokine release syndrome. And there may be some benefit in terms of decreased neurotoxicity as well. Plus, we do have other CAR Ts that are coming, like Anito-cel, which we may get approved by the end of the year, that appear to have lower rates of delayed neurotoxicity, potentially as low as 0.
So, Amrita, you in your talk got into the Majestic 3 study, looking at teclistamab with Dara, with big, ChatGPT said it was the paper of the year, incidentally, on I asked ChatGPT and myeloma, and I think everybody kind of agrees with that. But you, in your talk, you were contrasting the data between Majestic 3 and Cartitude 4, and this is kind of interesting there in terms of maybe what should come first. What's your overall take when you indirectly compare the data there? And do you think this has any impact in terms of choice of what comes first and people are eligible for both?
I mean, when you saw such a good PFS curve from Tech 3, naturally that became the question then, right? With an off-the-shelf option, where does CAR T fit in? I did put this in just to point out they are slightly different patient populations, right? But so I think with that caveat, both are really just good options to have. The challenge, it really becomes just a CAR T versus a bispecific question, fixed duration, one and done, toxicity and access. But I think to my mind, it really just says that BCMA-directed therapy has moved into the first relapse setting.
So, Bob, any thoughts? Again, in general, people usually kind of think more about CAR T because it's, as Amrita was saying, one and done. But also there's, I don't know, maybe it's just kind of the general feeling that, it may be more effective. But when you look at the data, there are incredible outcomes there in the Majestic study. Any thoughts, Bob? And it's certainly for people who are not eligible for CAR T, and they're eligible for bispecific, it's a great option. But could you see the situation where you go bispecific first or, bispecific Dara first, Bob?
Yeah, for sure. And I think Amrita highlighted this in her slide. I think the only downside to the Tech 3 data is that the vast majority, 95% of them, were Dara naive. And I simply don't have any Dara naive patients in my practice from frontline therapy. I do think that they look very wonderful. The only concern I have is in terms of sequencing, because it looks like with CAR T, you have a lower risk of emergence of BCMA mutated or deleted clones than with T-cell engagers. And that may change because as we go to discontinuous use of T-cell engagers, the selection pressure and the mutation rates may get lower. But at least for right now, if there's equal access, I would still prefer to give a CAR T first, because I think that in addition to the time of therapy, you probably preserve the target for later reuse better with a CAR T than with a T-cell engager.
So let's talk a little bit about linvoseltamab. Amrita, you talked about some work that's been done with myeloma relapse disease, but also systemic amyloidosis. Any comments about the linker MM1 study, Amrita?
I think, this becomes the challenge of how do you pick among BCMA bispecifics, is there anything really differentiating? Because the overall response rate's about the same at 71%. CRS was lower with Linvo, so that may be, attractive. But I think it's going to be very individualized per institution. How do you pick among your bispecifics? I don't see that as a differentiator. It may be schedule that may be more differentiating. The amyloid data, I think, is really exciting just in terms of amyloid's an ideal population in terms of a relatively low tumor burden and getting rapid, quick responses. The VGPR rate was 100%, right, in the amyloid-treated patients. So I think that's incredibly exciting. And they saw organ responses too, 73% renal response and about a third of patients having a cardiac response. So all those things really cement its role, to my mind, certainly for amyloid.
Bob, anything you want to say in terms of choice of bispecific, and also these are really fascinating results in amyloidosis?
I think, as Amrita mentioned, the bispecifics that target BCMA have roughly similar response rates. There may be a slight advantage to Linvo. It does seem to have a slightly lower infection rate. So it really comes down to what you're comfortable giving. But for amyloid, I think this is going to be a huge game changer, because the more rapidly you can get rid of that pathologic light chain and get it down to below measurable levels, the more rapidly we're hopefully going to be seeing organ responses, or at least stabilization of organ function, because there's not enough of the amyloid light chain around anymore to form the fibrils in the tissues.
So let's talk a little bit about talquetamab, the GPRC5D bispecific antibody, Amrita, that you talked about, the Monumental 1 study. Can you talk about what was seen there? In particular, chat a little bit about tolerability issues with talquetamab.
So, I was actually part of the Monumental 1 study, so I can appreciate the learning curve that it takes to use GPRC bispecific antibodies, namely the on-target off-tumor toxicities, right, in terms of dysgeusia, the skin and nail toxicity. I think two things. One, the response rate is very good. It's pretty comparable to BCMA targeting bispecifics, but the fact that we also saw good responses in people with previous T-cell redirected therapies. And the point I want to make there, because I literally had a lot of those patients, we didn't understand about sequencing when we did Monumental 1, right? So we would go straight from teclistamab to talquetamab, right? And so there wasn't these ideas of washout periods, or similar with CAR T. So the PFS was about 7 months in the prior T-cell redirection cohort. But, I think we've all seen even better results when there's been more of a washout. And I think the combination data that you're showing right now from the TAL3, of course, earlier lines of therapy, but it really suggests combinations with talquetamab are very potent, and I think really also how we will use it in the future.
Bob, any comments on sequencing? Can you go from teclistamab to talquetamab? Do you do that? And in particular, what have you observed in terms of tolerability issues, and how do you prevent and manage them?
Yeah, I think the other issue to bring up around talquetamab is that it seems to have a lower risk of infection than some of the BCMA targeted therapies. You don't get quite as much hypogammaglobulinemia, so that can be an advantage in certain cases. I don't think we have enough information yet to know whether we should do a BCMA first and a GPRC5D next, or the other sequence. But I would probably try to avoid going from one T-cell engager, as Amrita mentioned, immediately to another T-cell engager, just because T-cell exhaustion can be such a significant issue. And that's where, hearkening to my earlier point, it may be interesting to use some of these cell mods to try to recover T-cell function. From a toxicity perspective, I think the most important thing is to try to manage the dose and the schedule and to adjust for those people who do develop these various skin and nail and taste changes. And some of them can really lose quite a bit of weight with the talquetamab, and probably the same will be true, at least to some extent, with other GPRC5D targeted therapies.
I think the other thing
So
interesting that Ajay Chari's work showed is there is some degree of correlation of response with toxicity as well. So probably speaks more that you have active T cells, but at least that's something to also tell patients to encourage them.
Oh. Wow, that's really interesting. I didn't know that. Interesting. So no CME program in oncology nowadays will be complete without talking about an ADC. And hey, we got one here too, and a really interesting. We're talking about how great anti-CD38 is, but Dream 7. You want to talk about that, Amrita? I mean, to me, this is when I saw the Dream studies came out. It was like after everything that had been through in the past with the FDA and all that stuff, and then boom, amazing. Anyhow, you want to talk about Dream 7?
I mean, I'd say kudos to them because they were brave, right? They didn't do the triplet versus doublet. They really went triplet versus triplet, and they went against the big gun triplet, as you said, the CD38. And they showed a significant PFS benefit and even more, which is probably what got them the approval, right? An OS benefit. So I think that is all amazing, and there certainly is a place for it in its use. I think the challenge has really been finding a home, given the plethora of other options now, and it wasn't help with Majestic 3 coming out, right, in that early relapse space. So because even with Dream 7, that trial was not CD38 refractory patients, so it's sort of a similar type of patient population. But I do think it is a very active drug.
So, yeah, I mean, those curves that's Dara is the lower curve there, which is pretty impressive. Anyhow, anything you want to add in terms of Dream 8, looking at bortezomib versus belantamab, Amrita? Same kind of story?
Yeah, I think most of us, and maybe Bob can give his opinion, we're sad that Dream 8 didn't get approved, right? Because most of us think Palm is a better partner. We don't love using bortezomib again, just because most patients have some degree of neuropathy. And just from a mechanistic standpoint, at least, I do think the Palm combination is probably leads to more activity. But, you have to use what you got approved. So that's what we have right now.
Well, you can also talk about what you'd like to do, and maybe the NCCN will bless it or the FDA will approve it. Bob, what's your take on this, and where does belantamab fitting in right now in your own management outside of trial?
I think belantamab has a lot of advantages. First of all, it brings in a mechanism of action called immunogenic cell death, which may help to boost the patient's immune response by releasing tumor-derived antigens. And that may be part of why it has such a dramatic benefit. And then I would say that there also were data that were only in abstract form a few years ago, but that talked about BCMA expression being better preserved after a belantamab-based therapy than other BCMA targeting therapies. And again, that may be an advantage because you don't want the BCMA to go away. You want it to be there so that you can reuse it as a target. And I think, for example, because we now give the belantamab less frequently than we used to, I think it's a big positive for people who don't want to or are not able to come to the office to get treatment quite as often, which can be a sizable proportion of folk.
So we were talking a few weeks ago about the belantamab story with the FDA, and people may not remember, but actually the ODAC voted against approving it. And right around that time, we did a survey of myeloma investigators and said if belantamab, because remember, it went off the market. It was available for a while, then it got taken off the market. because there was a trial, the phase 3 trial that wasn't positive. And then the ODAC said, don't approve it because of the ophthalmic toxicity. And then we surveyed like 20 myeloma investigators. We said, how many patients in your practice, if any, would you give belantamab to right now if it were approved? And the average was like 5. And then fortunately, the FDA actually approved it. How has the ophthalmic toxicity played out, Bob? You know, initially there was a lot of concern. I think that was the ODAC concern. But then we kept hearing, you know, delay it, hold it, increase the interval between therapy, and actually maybe this is really not a big problem. Is that kind of the way it's playing out?
Well, there's definitely ophthalmologic toxicity to at least some extent in a substantial proportion of people. You do need to have an ophthalmologist who is experienced, but with less frequent and lower dosing, it definitely can be a very manageable drug. And I think the activity is such that it's definitely worth a look for all the reasons that we've talked about.
So, Amrita, you were saying before we started here, you weren't sure where belantamab was going to, where it was going to fit in terms of first-line therapy. And I'm just a real simple person. I look at that per curve compared to Dara, and I go, well, why wouldn't it be in first-line therapy? You're there in SWOG trying to figure out what to do next. What do you think about these trials looking at belantamab up front?
Well, I mean, there was the DREAM-9 trial that got updated at ASCO this year, where they tried to mitigate some of that ocular tox with different schedules and doses. And so many doses, so many schedules. But the bottom line of that trial was you still need to have some dose intensity at the beginning to really derive that same high rate of MRD negativity. So I think it still becomes this balance to work out. And now the interesting thing is they allowed ECOG 0 to 2. They didn't exclude frail patients, and they had patients over the age of 80. So I think the space really is going to be in patients where you don't want to give a BCMA bispecific in the upfront setting. That's where this is a good BCMA-directed strategy to use.
So another paper presented at ASCO was looking at another BCMA bispecific, E10-TAMIG. I'm not sure if I pronounced that correctly, but they presented data at ASCO that Amrita reviewed. In a lot of ways, it kind of looks like, you know, the other bispecifics that are out there. But the thing that was really interesting, and I've been hearing about this even from general medical oncologists, is the use of prophylactic tocilizumab, Amrita. Any thoughts about that? And I mean, I see people doing that in practice. Is that something you do? Interestingly, they don't do that with the bispecifics in lymphoma, but it seems like a pretty effective strategy. But you tell me, what do you think, Amrita?
I mean, so we actually adopted this because we do bispecific as outpatient, and we give everyone prophylactic tocilizumab. And certainly our CRS rates are not 0, but they are, usually all grade 1. I'm sure you might want to talk about the OPTEC trial, right? That was also at ASCO, which was outpatient TEC or TAL, giving prophylactic toci. They had about a 5% CRS incidence in one arm and about 14% in the TAL arm. So again, much lower than what you saw just without Profi-TEC. Toci, right, which is usually about 70% CRS rate. So I do think this is much more now proof of principle that prophylactic toci can reduce your CRS fairly dramatically and make outpatient step-up dosing much more feasible for many more centers.
Bob, any comments on this one, the OPTAL prophylactic toci strategy that was again presented at ASCO?
Yeah, definitely an attractive approach. People also in the community often will do pocket dex so that folks have small doses of dexamethasone that they can take with them home and take if they are feeling just having a little bit of a temperature. There are wearable monitors that may be of help. I think the other big change is going to be in engineering these T-cell engagers, because several of them now have CD3 binders that bind more weakly and therefore don't induce as much cytokine release. Plus, the other benefit is that if you're not poking the T cell constantly because of lower affinity, you may get less exhaustion and therefore fewer infections down the road. So that's being done with a couple of these molecules, including, I'm not sure if you're talking about this, but there's the trispecific antibody that several folks are developing that target both BCMA and GPRC5D in one molecule.
How does that play out in terms of tolerability and efficacy?
The efficacy numbers have so far been pretty impressive with those trispecifics, and the tolerability has been at least as good as a single TCE, and in some cases, they look even better.
So, Amrita, I'm curious right now where things stand in terms of bispecifics in the community, how you interact with a community-based general medical oncologist. Are you still starting patients in general in your center and then sending them back to the community? What about outpatient bispecifics in the community, prophylactic TOSI? Where is that now? Where do you see it heading, Amrita?
Neil, you're always asked the good questions and the future thinking, because that's exactly kind of our push now of how do we get more uptake in the community. I think to Bob's point, the trispecific is particularly well suited to the community because it's one step-up dose. The trials are going on right now actually using prophylactic TOSI, and there's going to be a randomized trial, prophylactic TOSI versus no, so hopefully you can even get it as part of the label, which I think will also be important and impactful in terms of using it. So I think our thing is to encourage the community to start thinking about using it. Bob mentioned earlier the quote-unquote pocket dex, which many of us also tell patients, low-grade temperature after your initial step-up dosing, take the dex at home, and often that can keep patients out of the hospital too.
Yeah, I remember at ASH, we had a community oncologist presenting a case to one of our programs, and the patient didn't want to go to the tertiary center. So she had to actually treat the patient, and the patient did great. But it was her first, and she was like, the patient called in and had a fever. I told him to take the steroids, and the patient did great. So hopefully that'll come up more in the future. Getting back to that trispecific, Bob, do you see the dysgeusia and other things that you see with talquetamab with that?
Well, interestingly, so far it seems to be a little bit less. Part of that is because the dosing is lower than just head to head. And so if you give less of the drug, it's going to be a little bit better tolerated.
Interesting. Amrita, what about other types of CAR T therapy? I always love trials in progress posters. This is one here I think this is from ASCO, looking at the Quintessential. I always like cool trial names. I kind of like this one, Quintessential 2, Orlowski. Why is this different than the other CAR Ts, Amrita, and what other newer CAR Ts are coming out?
So Orlowski actually targets GPRC. So I think now that we're talking about sequencing, where are we going to use it? If BCMA-directed therapies are going to be moved, they're already now approved in second line, probably very near future first line, you need other targeted options for patients. And so, this is very timely and this would be the first CAR T targeting GPRC. So there is a huge space. The phase 2 trial very appropriately included patients who had prior BCMA targeting therapies and showed no difference in PFS. So I think both of those things suggest it has there is an unmet need. It's very encouraging. The only caution I would add is the cerebellar toxicity that they did see. So there's no free lunch, right? We saw with BCMA CAR Ts, we see a certain kind of neurologic toxicity. With GPRC CAR Ts, we see a different kind of neurologic toxicity. So understanding as that gets used more, how to mitigate that will be important as well.
Cerebellar tox. I mean, we were talking before about the Parkinsonian type thing with cilta-cel. What do you see with the cerebellar toxicity?
Generally ataxia or dizziness. The mild case is dizziness, more severe ataxia.
Bob, what about this dual BCMA CD19 CAR T cell therapy that's being developed? A naive central memory phenotype and induces a rapid decline in soluble BCMA. Any comments on that? This is from EHA.
Yeah, I think there's a couple of interesting things about this agent. First of all, they use a faster manufacturing timeline, so it doesn't take as long to prepare the CAR T. It's only actually a few days. Now, there's still release testing that has to be done, so you don't get immediately back your CAR T, but it's definitely faster, which is going to be helpful for those whose numbers are really going up. I think the CD19 part of it would be really interesting for areas like Waldenstrom, amyloid, for 1114 translocated myeloma, where all of those have some B cell markers, including CD19. I'm not terribly sure that for other myelomas, CD19 is a necessary target or not, but we'll see what the data show.
Amrita, anything you want to add to that?
No, I mean, I think Bob summarized it well. Really, the manufacturing is definitely differentiating, and now we just need to see, is the CD19 portion of it differentiating or not?
So, final question to both of you. I want you to pull out your crystal ball and tell me how we're going to be managing myeloma 3 to 5 years from now. I'll start with you, Bob.
I think 3 to 5 years from now, we'll have upfront T cell engagers and CAR T cells. And I think for standard risk patients, we're going to be curing at least half of those where they will never need a second line of therapy. And for the half that do relapse, we're going to have even better options available, and probably another half of those will be cured during the second line, and myeloma clinics will be much happier, as of course will be patients and families.
When you talk about cure, I was flashing on. I remember when we first started doing myeloma, I think maybe it was 20 years ago, the Sagar had this thing with the iceberg, and now his iceberg diagram in that high-risk thing has gotten a lot more complicated. And again, Amrita, anything you want to add to that in terms of where we're going to be in the next few years?
I mean, I agree with Bob. In the next couple of years, it's going to be BCMA-directed strategies in the front line. My hope is 5 years or more later, we're going to have actually trispecifics in that frontline setting, fixed duration with curative intent. And as much as I hate to say this, I think in the US at least, upfront transplant is probably going to diminish it in use. I don't want to diminish its validity ex-US because it is a very effective therapy, because in the context of other treatment options that you have available to you.
So Amrita and Bob, thank you so much. It's really amazing to do these year in review programs. We can barely get through these things in an hour nowadays, and so many other things to talk about. Really exciting time to be in oncology. Audience, thank you for attending. Be safe, stay well, and have a great night. Amrita, thank you so much.
Thank
Bob,
you.
thank
Bye-bye.
you so much.
Thank you.